subarachnoid hemorrhage. Surendra, carry on.
షేర్ చేయాలేమో ఒకసారి ఇది షేర్ స్క్రీన్
కింద షేర్ అని ఉంటుంది కదా.
చూసాను, చేస్తున్నాను సార్. వచ్చిందా సార్?
వచ్చింది. స్లైడ్ షోలో పెట్టు. స్లైడ్ షో ఓకే, క్యారీ ఆన్.
Good morning everyone. And really within short notice period that Mohan sir given for me to talk about SH, I prepared in a basic manner only, even though so many new guidelines came in the SH, but there is not much practical difference in the management. So today I am presenting briefly about the subarachnoid hemorrhage, what is the role of intensivist, and how you have to routinely manage in the ICU. Subarachnoid hemorrhage is the just for anatomy. There is a the subarachnoid space is the space between the dura mater and the pia mater, where the brain will get the blood supply from the blood vessels. There could be rupture of the blood from the rupture of the blood vessel and leading to bleeding in the subarachnoid space. And the most common etiology will be the one. It is usually etiology will be classified into traumatic and non-traumatic. And traumatic usually seen in the traumatic brain injury. The management of traumatic SH is different, and non-traumatic SH is different. So today mostly we will discuss about the non-traumatic only. Lastly we'll have a word about the traumatic SH also. The most common with the aneurysmal rupture, we all know that, and there could be AV malformation and fistula also, and could be an vasculitis and coagulopathy, and those are having the history of drug abuse like cocaine abuse, and uncontrolled hypertension has the high risk for having a subarachnoid hemorrhage. And this is just diagrammatic showing that how the aneurysms will have the saccular and fusiform, and next to the ruptured aneurysm. Usually the aneurysms mostly seen at the diversion of the blood vessels, where there's a shear force is high at the diversion of the blood vessels. Those are having high risk of tendency to have a shear blood vessel dissection. They will have a more of aneurysms. And prevalence of aneurysm in the normal population is around 1 to 5%. Most some patients will have a multiple aneurysms. Only 20 of them usually ruptured in the lifetime. And old data India is this is the data that is shown in the it is only mainly in the major hospital and the data is collected. It could be higher also, because most of the cases may not reach the hospital also. They die in the home or transport. And risk factors usually will most seen in the female gender, and smoking, those having a history of smoking, and connective tissue disorders like Marfan's and Ehlers-Danlos syndrome, and those having polycystic kidney disease. And when I'm doing residency, I've seen one young patient of 25 years patient who's admitted in the ward. Patient, I attended for a code blue. Patient is having ventricular tachycardia. I've seen the patient, revived the patient. Actually, he admitted mainly for the abdominal discomfort. He's having pancreatitis, and when he revived, and we had done a CT scan, as patient is not improving sensorium. Patient is having very huge SH. So this is the when we screened everything, patient is having polycystic kidney disease. Because the history of why the history is important, because we need to screen those having polycystic kidney disease. We need to screen their first and second generation also, because they will have a high risk of aneurysmal rupture. And this is what I already told. And most of the aneurysms usually seen in the anterior circulation, and less will seen in the posterior circulation. high data is showing usually the aneurysms at the intra skull internal carotid artery having the high risk, having the most of the aneurysms, and anterior cerebral artery, and less of in the posterior cerebral artery. So the prognosis will be good in the anterior circulation only. If the patient is having higher grade of SAH in the posterior circulation, they will have a very poor prognosis. So how they mostly presents is when patient is having a worst headache of his life and having meningeal signs and loss of consciousness, and it's a stroke-like symptoms, having focal deficits, not moving his limbs and not moving his lower limbs. And if one recently I have done one patient, a patient usual female around 40 years came for the patient presented like meningism. I have done LP. LP is showing reddish colored. I immediately called neurophysician that patient is having a reddish colored LP. He thought it could be a blood tap, but I have a doubt about this patient, sir. Then they have done one CT angiograph. They showed a very big anterior cerebellar aneurysm. And some of them present with the third nerve palsy and sixth nerve palsy also. Then the patient is having any posterior circulation SAH, and some may present with aphasia and hemiparesis and left-sided visual neglect. If patient is having like patient may present the MCA infarct also. And the newer guidelines 2023 AHA guidelines, they have introduced a whatever SAH. Patient is having the patient is of 40 years and any meningeal signs and any LOC and higher severe grade of headache, we need to evaluate the patient immediately. You cannot neglect the patient because SAHs we need to treat as emergency only because it has a very high morbidity if you don't treat. It has an excellent prognosis if you treat at a good time. And we all know that CT is the gold standard one. And if it is negative, then you need to think about what is the other probable cause. If it is positive, definitely you need to go for angiograph, CT angiogram to find out the aneurysms. If you find out is okay. If you don't find out, then also you need to go for the distal subtraction angiography, because less than 5 mm aneurysm may not be picked by the less than 2 to 3 mm may not be picked by the our CT angiogram. Definitely distal subtraction angiography definitely picks up the minor small aneurysms also, and it picks up the multiple aneurysms also. This is the what they have given on flow chart. If the patient is present with severe headache within 6 hours, no neurological risk, do a CT. If SAH is there, okay, we need to go for angiography and distal subtraction angiography and determine the treatment part will determine by the according to the grade of the SAH and patient status. And if you still unable to find out in the SAH in the CT, then you need to check with the LP also, check for the xanthochromia. And usually CT scan picks up most of the things, and MRI usually doesn't less sensitivity detect the flare, but flare may show the flare image of the MRI may show the SH. And you cannot, you may misdiagnose SH as some other migraine or sinus related headache or any psychiatric disorder, or it could be patient usually present with the fall in the bathroom or fall in the some other unknown area. You think that patient may got with some head in that the scalp laceration. It could be that might be causing the headache and all those things. And usually they present with the ST elevation, ST depression. You are treating like cardiac patient. Don't neglect it. If you have any doubt about the brain issue, better and evaluate the patient. And we'll discuss this in the grading in the later part of time. And you need to why hello. Why you have to do CT? It picks up the cerebral edema, hydrocephalus, IVH, and any edema is there. How is the grading? Usually you will grade with and what is the risk of the vasospasm will be usually graded by the CT scan. So early CT scan, our patient is any deteriorating in the sensorium, go with the repeated CT scan, definitely find out the cause and treat according to the patient status. And some of there is a pitfalls in the CT diagnosis also, because if you do very lately, if you are doing CT scan at second or third day of the onset, if the hematocrit levels comes down, you may not pick up the blood. Or if patient is having small bleeds and perimesencephalic bleeds, you may not pick in the CT scan also. And there could be bony artifacts you may see in the brainstem area also. You may miss the bleeds. Then if you have any doubt, you can go with the LP. LP will show like that's xanthochromia. And the only one point I want about in the LP, when you're doing LP, if you get a blood color thing, collect in 2 to 3 bottles, ask the lab technician to check for the count of RBC from the first bottle, third bottle. If it is constantly maintained, it could be SH. Or xanthochromia, definitely confirm the SH. And definitely you need to diagnose it correctly and right time definitely makes the difference. And if you have a doubt, if you have doubt in the CT scan, definitely gold standard will be ask our interventional radiologist to go for the distal subtraction angiography, check for the aneurysms. This is what this patient is having multiple. This is the patient is having aneurysms and the anterior circulation. This is the CT scan. This is the CT scan is showing the aneurysm. CT, that is the rotational angiogram, 3D rotational angiogram CT scan showing the aneurysm. And if you are unable to do the CT scan, then you can go with the MR angiography where the patient is having an AK and suspicion of contrast-induced anaphylaxis and nephropathy. Then you can go for MR angiogram. Definitely, it can also pick, but less sensitivity is less than the DS and CTPA. And there could be angiogram negative subarachnoid hemorrhage. It could be due to the patient is having severe hypotension or vasospasm or any poor angiographic technique or thrombosis of the vessel can also have the angiogram negative subarachnoid hemorrhage. And this is the picture showing the small bleed in the perimesencephalic area. Usually they will present with the headache. You may not see that spider web like CT scan. But usually this is having good prognosis in the perimesencephalic area. They will have a very less chance of delayed ischemic, cerebral ischemia, vasospasm. And how the SH affects the other system is also one of the important factors. Usually, as the patient has a bleed in the brain, it's always a patient have a risk of the seizures, hydrocephalus, and patient as the patient needs higher blood pressure, and they will have a sympathetic surge, may hurt the lung and heart. They will have a erythemias, ST depression, ST elevations, and VT and VF, and they will have a stress cardiomyopathy and Takotsubo cardiomyopathy also. Sometimes you may see the patient will have a good cardiac function with neurogenic pulmonary edema also, as patient is having sudden sympathetic surge may cause the capillary vessel dilatation leading to the filling of the alveoli. And next one thing is the sodium. There is the problem with the sodium homeostasis. They will have 2 types of sodium problem. One is usually you will see the hyponatremia. Hyponatremia you may see in less cases, but hyponatremia there are 2 tests. One is cerebral salt wasting syndrome. Another will be the SADH. They 2 are differentiated mainly by the volume. When how we differentiate mainly by seeing the clinical status of the patient and by the monitoring of the patient. If the patient is hypovolemic, always treat the hypovolemia. You need to maintain the euvolemia. If patient is if you have a suspicion of cerebral salt wasting syndrome, this patient is losing so much of salt to the urine, then you can add the fludrocortisone or mineralocorticoid therapy to prevent that cerebral salt wasting syndrome. And if you want to treat, you can treat with 3 pence NaCl. Better to avoid that tolvaptans early of the SH management, because it may cause a free water loss and hypovolemia also. And what's our goal? Mainly will be our goal always will be the initial stabilization, and never forget our airway breathing circulation when our patient is sick, if having GCS of less than 8, and you need to intubate the patient. And how we are grading is will be the Hunt and scale and WFNS scale. If a patient is having any asymptomatic mild headache, you have suspicion, you need to imaging and find out the SH. And severe headache and nuchal rigidity will be the grade 2. And patient with confusion and mild focal deficit having 1 hour, 2 hour palsy, it is grade 3. Patient having stupor, hemiparesis, and early disability, these are grade 4 and grade 5 are severe grades. They will have a poor prognosis in the, even if you treat also, and you need to intervene very early in this patient. And the World Federation Neurosurgical Society has given the GCS with GCS, if they need drop in GCS along with motor deficit. And it is a Fisher grade scale. This is the classical star sign appearance of the SH. Why it indicates if patient is having very thick blood in the intraventricular space or in the subarachnoid space, they will have a high risk of vasospasm, and they will have a poor prognosis, and they will have a future. They will usually present with the hydrocephalus in the coming days also. So we have done our ABC, and we have done our grading of the thing. And our next plan is, if the center is expert center having neurosurgical and neuro intervention, neuro radiology thing, you need to keep the patient. Otherwise, better to transfer to the having the advanced center. And we need to do the routine care monitoring of, you need to check for the ECG and hemodynamic status and volume status also. If the patient is already on some warfarin or something like anticoagulants, you definitely need to reverse as soon as possible, because it enhances the bleed and increase the ICP and increase the mortality. And always remember, if patient is having having unsecured aneurysm with high amount of bleed in the brain, always patient have a high risk of seizures. Most of the patient present with the seizures also. So in these patients, we need to give anti-epileptics early. But the one thing I want to add, better, they have found out in the recent guidelines, they have given phenytoin, you need to avoid, because it increases the morbidity and mortality in the patient who's having SH. So we need to avoid the phenytoin. Next, fluid management. We need to go with the crystalloids only. Better to go with, you can go with NS or balanced crystals like a plasma light. They have done one trial with albumin to maintain the intravascular space volume. They found that there is no benefit with the albumin trial. They found no benefit with the albumin. And we need to maintain the sodium at a good level only, that 145 to 155. And you need to, if the patient is having unsecured aneurysm, definitely you need to keep the blood pressure less than 140/100. If you have secured aneurysm, you can keep the blood pressure on 160 or 170. But if it's unsecured, always keep the blood pressure rate low. So how you have to keep two things. One is early starting of oral nimodipine. Definitely it prevents the rise of blood pressure, and you can use the labetalol, and you can use the other calcium channel antagonist. Better not to use the NTG in the patient is having any intracerebral bleed. And always you need to go for DVT prophylaxis. Don't give any anticoagulants. You need to go with compression stockings only. And another important point is, you need to always, in the whole period of the patient, you need to always prevent the fever. As fever increases, the BMI have the risk of basal metabolic rate, and increase the risk of seizures, and increase the there could be problem in the brain and increase the brain damage also. And you need to always keep the patient calm and composed on the bed, if it is unsecure, keep the patient sedated, giving some fentanyl and midazolam. If the patient is really agitated, go intubate the patient, intubate and ventilate the patient. And always you need to go with hourly neuro check. You need to have a good nursing team and other staff to maintain the hourly neuro check and input and output chart. And you need to give stool softener, prevent the cough, and you need to start nimodipine as early as possible. And mostly how the SH is going to affect, already I think I discussed this thing with how is affect the SH. It is having a risk of vasospasm, hydrocephalus, and cardiac complication and pulmonary complications. And what is our, you found out SH, what is our next will be our definitive management. How you are going to treat the patient. We have first we have stabilized the ABC, you have controlled the blood pressure, you are maintaining euvolemia and starting oral nimodipine early, transferring the patient, transferring to the tertiary care center with having a neurointervention, neurosurgical team. And next, what's our plan? How to prevent? Mostly our goal is to stop the bleeding, and if the aneurysm rupture is if the aneurysm ruptured, you need to prevent the rebleed. That's our main goal. It can be done by one thing. There are only two. One thing, one is coiling, another is the clipping one. These two things, what we have to do, definitive management. So what the recommendation says is, the patient is having ruptured aneurysm, always better clamp it as within 24 hours, definitely improves the survival. And you can go with coiling or clipping if it is ruptured. If you are able to coil it, it's okay. If you are able to clip it, it's also okay. And patient with ruptured aneurysm in the posterior circulation, what they say is always go with the coiling. It has a good it is preferentially coiling because it has a good neurological outcome, because less surgical stress and less stress on the patient. And if patient is having hydrocephalus and large intracerebral hematoma, always open the skull, have a decompressive craniotomy, evacuate the clot, and put a EVD and decrease the intracranial pressure. Next, if patient is having higher age, more than 70 years, always go with the, if he is amenable for coiling, always coiling will be the best than the clipping. And less than 40 years, if it is both, if this patient is having anterocerebellar anterior circulation aneurysm, you can go with the coiling or clipping also. Both can have a similar outcomes. But have a good grade of SH, or 1 or 2 or 3 of there is a aneurysm, better always it go with the coiling, definitely improves the outcome than the clipping. For patient with good grade SH, ruptured aneurysm of anterior circulation equally suitable for both primary coiling and clipping. Both treatment options are reasonable to achieve favorable long-term outcome. This ISAT trial showed always the coiling. If your patient is having a low, that is a good grade of SH, that is 2-3 grade of SH, if coiling have the less surgical stress and good patient, and you need to obliterate the vessel completely. You cannot leave it half cooked surgery. If you complete obliterate the vessel by coiling or by the placing stents, definitely it improves the 1-year surgical outcome. And there are some endovascular agents. If patient is having a very large wide neck aneurysm, not amenable for surgical clipping or primary coiling, endovascular treatment with stent assisted coiling or flow diverters are reasonable to reduce the risk of bleed. I have seen in our ICU, some they are placing on flow diverters. Those are having very huge aneurysms to decrease the flow to that aneurysm area. and patient with SH from ruptured fusiform or basilar blister aneurysm, use of flow divers is reasonable to reduce the mortality. But the recommendation is grade 2A only. And if patient is having the good outcome with the coiling or clipping, by placing flow divers definitely is not going to help. If it has low neck, it is easy to coil, definitely go with the coiling or clipping only. This is how they will place. This is the they will go to the aneurysm. They will place the wires, platinum wires, and they will completely occlude the vessel. And this is how the neurosurgeon will explore that aneurysm, and they will place a clip. This is a definitive treatment. And whom will be the will prefer the clipping? If patient is a large SCH and MCA aneurysms and wide neck, blebs, geometrically complex with incorporation of branched artery, and it is partially thrombosed, and it is a giant one. And definitely if there is a difficulty in the navigating to the artery also. And coiling is preferred in the posterior circular stroke and elderly people. And I already discussed SH is a neurosurgical and neurointerventional emergency. High index of suffusion is always required. Securing aneurysm definitely improves the outcome. And our outcome will be determined by the age and our if you have a poor grading of WFN as a Fisher or Huntington's and size of aneurysm is big, and if the severe if patient has developed a severe vasospasm and seizures and cerebral edema, definitely they will have a poor outcomes. And next, we had on our definitive management. What are the things we will expect? What are the main things what we will expect in our immediate post surgery? Will be there are three things. One will be the rebleeding. How you are to prevent the rebleeding is mainly by the definitive surgery, management, the clipping and coiling. And there are one trial, then ultra trial, using of antifibrinolytic agents, aminocapric acid and tranexamic acid. They found out is initially they had good result, but the recent guidelines showed there is no benefit of using tranexamic acid in the subarachnoid hemorrhage patients. And next will be the hydrocephalus. Because why the patients will have a hydrocephalus is mainly because the occlusion of the blood, in the occlusion of blood during CSF absorption and flow of the CSF may cause the hydrocephalus. If you found patient is having hydrocephalus because decreases sensorium, having low gaze palsies, then immediately do a CT scan and go with the placement of EVD. And when the patient is hydrocephalus, always better to monitor the ICP whether with the transcranial Doppler or any other conventional methods, because you need to keep the pressures little bit high, otherwise the brain tissue may have the hypoperfusion. And next thing, will be our main goal is to prevent the vasospasm. Why the vasospasm occurs in the subarachnoid hemorrhage only? Mainly because the blood products, when they lies in the second and third day, they cause the release of some substances causing the severe vasospasm causing irritate the blood vessels, causing vasospasm. And if the vasospasm occurs, it completely it acts like acute ischemic strokes and blocks the whole artery and decrease the perfusion to the distal area of that distal area from that circulation. How you find this is clinical and your monitoring and your radiological. Clinically, patient will have a seizures, focal deficits, and have a low GCS, decreased force score. And next will by the monitoring, when you may see that if you have a transcranial Doppler, you can find out that the increased peak velocities in the transcranial Dopplers and increased Lingard ratio in the transcranial Doppler. And next, you can see some EEG abnormalities in the EEG. If you have a continuous EEG monitoring, you can see the EEG abnormalities also. Next, if you have a suspicion, we need to move to our radiological diagnosis by the CT angiography or you have to do immediate CT to rule out other confounders, and you need to go for distal subtraction angiography to check for whether there is a flow or not in the distal to that area immediately. Then if you confirmed of delayed cerebral ischemia, that is vasospasm, then you need to intervene as early as possible, because your brain will damage very fast. If patient is anyhow, we will start oral nimodipine as early as possible and TCD monitoring. And if patient required multimodality neuromonitoring, invasive one also, we can go ahead. Patient is having higher grades of SH, you need to go with multimodality monitoring. And before that, there is one what they're given is so many people ask us to increase the blood pressure very higher level, and coil did, clip did, keep it higher level. That may harm the patient, keeping the BP as more than 180, 190, 200, because it will cause the increase the risk of the tropospheric cardiomyopathy and other aneurysm rupture and stress on the other systems. So it may not useful. But if you found out the patient is having is confirmed vasospasm, your goal is now the proven therapy. It's not the triple H one. Now the proven was as two things. One is euvolemia, and another thing will be the augmented hypertension, and prevent the hypotension. You can keep the patient with little bit hypertension and 160 to 180 to keep the vessel perfused. As we see in the acute ischemic stroke, we don't decrease the blood pressure rapidly to the less than 160, 180, because definitely the penumbra will be high if you decrease the blood pressure. So we need to keep our blood pressure at a little bit higher level using our vasopressin, noradrenaline, or phenylephrine to keep the brain perfused. And if you got a diagnosis of delayed cerebral ischemia by your DSC or CT angiography, then what you will ask the interventional radiologist to rescue therapy. If you can first, if patient is resolved with your euvolemia, giving fluid bolus like crystalloids, and keeping the blood pressure, you got the perfusion, it's okay. Otherwise, what they will do is they will go to that artery, specifically like coronary how we do in the cath lab. There's a coronary angiogram. They will go to that artery. They will go the balloon angioplasty, or they will give some drugs like that is calcium channel blocker, oral nimodipine, nicardipine, verapamil. Initially they used the papaverine, but papaverine definitely doesn't have any significant effect, and it has high morbidity and mortality. Now they are not using papaverine. They were now using the calcium channel blocker, and another drug is the milrinone. So to relieve that, our goal is to maintain the patency of the distal circulation. They will go back, but they will do the balloon angioplasty, and they will place if required, they will place a stent, or they will give a spasmolytic. If it is results, okay. Otherwise, they will come. You need to do our conventional management, keeping euvolemia and keeping the blood pressure a little bit high. Definitely, two things you should always avoid in this when patient is having delayed cerebral ischemia. One is hypovolemia, one is hypotension. This is what I discussed right now. And definitely patient have a medical complication. Always these patients have medical complications of pulmonary embolism, infections of the surgical infection, and other normal ICU complication definitely will be there in the SH patient also. Our goal is mainly to prevent the infection, fever, and hypotension is our main goal, to prevent the delayed cerebral ischemia and sodium homeostasis, because it increases. If you have a patient with hyponatremia, definitely increase the ICP, and you need to decrease the ICP as well. And discuss the hydrocephalus, we need to place a EVD. And for this, I think I discussed the seizures. We want to the prevention of seizures, and those will have prophylactic use of seizure medication may not be indicated in the SH patients, but patient unsecured aneurysm, thick aneurysm having more than 1 centimeter of the blood in the CT scan, definitely go for with the seizure prophylaxis. You can stop once the aneurysm secured and patient is conscious, and you can stop this and patient without anti-epileptic also. And I think neurogenic, I already discussed this one. This is the neurogenic pulmonary edema. And another thing, just I think I almost concluding my talk in another 5 to 6 minutes. And there are some additional points what I read in the short span of time, additional points to add our regular school of thought of SH management. Will be the transfusion thresholds for the SH patients. We need to treat like patient is having acute MI. You need to keep your little bit higher, keep the not transfusion threshold. Transfusion should be you have to keep your hemoglobin level more than 8. Or you have a high suspicion of delayed cerebral ischemia or having cerebral ischemia, keep the blood around 9 to 10. 9 to 10 is recommended now. And another thing I found is when I came to the Medicover hospital, they are using Mildrenone. I never read any Mildrenone in any book. I never used them, and they seen. Then I read in the literature. Actually, it is not included in this guideline. That's 2023 AHA guidelines. But what they found is the Mildred spasm study that published in 2021 to 22, I think so. They showed it is not well randomized and well controlled study, but they found they have a very good outcomes to prevent the delayed cerebral ischemia. If you are using IV Mildrenone, the patient have secured the aneurysm with coiling or clipping. If you start the Mildrenone, even it may, with the problem with the Mildrenone, it is inodilator, decrease the blood pressure. You can keep the blood pressure up along with an noradrenaline phenylephrine. They found that they have a good outcomes and less delayed cerebral ischemia, those patients treated with the Mildrenone. But I think what they written the bottom line, as every study, right, it requires more control studies, more meta-analysis to conclude this as a good definitive therapy. But I have seen in Dr. Sivasankar Dalai sir, he is using the IV Mildrenone. Even he is not using oral nimodipine also. I also shocked to that, but still I have seen that I think they recovered well only. Another thing, this is a clazosentan, there's endothelial receptor antagonist. They have done 2 trials, one is Conscious 2 and Conscious 3 trials. It is published in 2012 and 13 in AHA. It has showed definitely decrease the delayed cerebral ischemia, but the overall outcome is not having any significant thing. So we are not using at this point of time. Another drugs, the patient is having raised ICP, will use the mannitol and 3% NS. The one line they've written is mainly, if the aneurysm is unsecured, giving a mannitol is a detrimental one because it draws the fluid and you don't know the rheology at that point of the aneurysm rupture area. So you may hamper it. If you have a clear-cut signs of raised ICP, if you don't have any other option, or doing intrasurgical, you can use the mannitol. But if you want to decrease, you can use the 3% NSL, but judge clinically and patient, then use the mannitol. 3% NSL, I think you can use safely, but still you need to think before using. This is the what I will share these guidelines in the group. I think already, so many people know about this one. What they is early recognition of pre-hospital and emergency and clipper coil and post care and rehabilitation. This is what they have showed the good improvement in the subarachnoid hemorrhage and early brain injury by detection, prevention of early brain injury by the rebleeding, treat hydrocephalus, manage elevated ICP, seizures, and delayed brain injury by prevention of delayed cerebral ischemia, sodium dysregulation, prevention of fever, and don't forget hypo and hyperglycemia both can cause the injury. So glucose management also important. And early rehabilitation, headache and seizure management, and there's multidisciplinary explaining the patient attendance, multidisciplinary team definitely improves the outcome. and my take home message will be the improving timely and equitable access to healthcare system and resources such as you need to you need to have a resourceable and equitable early access to the tertiary care center definitely improves the outcome. And management SH, you need a dedicated neurocritical ear units, you need a good trained intensivist, you need a expert detecting, you need to do those who can do the transcranial Doppler to detect the vasospasm early. That you can detect it is in the bedside only. And one main thing, you need expert nursing care also. And do it within 24 hours, stop the bleed as early as possible, and endovascular and surgical treatment determined by the expert with the shared decision making only. And medical complication increases the mortality, and goal directed treatment definitely you need to prevent other things as your infection, and fluid management is mainly makes the difference. And if patient is on mechanical ventilator, you need to go with the bundle of care. And I'll discuss phenytoin is increase the morbidity. Don't use phenytoin in the SH patient. And you can prevent the DCI by monitoring with transcranial Doppler, CT angiography, or EEG and DSA, and maintain the UVL and augmentation of blood pressure when patient is having DCI. Early oral nimodipine increase the patient outcome. One thing I want to add, nimodipine. When I'm doing residency, we used to use the IV nimodipine also, but definitely IV nimodipine has a problem, because oral nimodipine is very good because it has a neuroprotective and influx of the calcium. Influx of the calcium in the blood vessels definitely it decreases the vasospasm, but not IV can increase the risk of hypotension, and risk of the hypotension not as good as oral. So recommend this oral, not the IV. You can give the injectable at the place of the artery. Don't give infusion through the vein. This is what the recent guidelines. I don't know the next update what this recent guidelines I'm telling. Repeated imaging. If a patient, you have treated the patient before shifting or any drop in GCS, always repeated CTs and repeated imaging definitely predict the early complication and improves the outcome. Imaging monitoring of development, and then I think I added this. Why I added this, the point in this take-home point is if your father or mother got an aneurysm, always the first 2 degrees relatives of SH, better to early they will ask them to go for the cerebral angiography to detect the aneurysms, because they have the high risk of aneurysm. They will have because of genetic tendency having aneurysm tendency and aneurysm rupture also. And last but not the least, among SH survivors, physical, cognitive, and behavioral and quality of life deficits are common and can persist. Early identification with validated screening tools can identify the deficits and behavioral and cognitive domains. You need to have a good team of physiotherapy and psychiatrist, neuropsychiatrist, and dietitian. We need to feed the patient with make him that he have a normal life, having cognitive therapy, and prevent the long-term cognitive dysfunction, and have a good patient outcomes. Thank you for giving this opportunity.
Thank you, Surendra. A very nice presentation and very new points you have mentioned in this talk. I would like to share my 2 experiences in SAH. One is recently our surgeon did a rare case. Only 100 cases are reported in the literature in the worldwide, and is the lenticular striate artery aneurysm, which is very deeply seated and difficult to put a coil to negotiate that area. So even surgically also it is difficult to enter to that point and put a clip. But they did successfully, and they are going to present that case in a neurosurgical forum, international forum. And another case, it is the diagnosis of this SAH is sometimes difficult, and as you said, a patient presented with ST elevation, and if you don't screen properly, and very careful history, you may treat it as a MI because of ST elevation and patient may succumb. That's very important history. No patient will admit with drowsy or severe headache in case of MI, right?
Sir.
So unless otherwise patient in shock. So another thing is one patient had a fall and had a femur fracture, posted for surgery, and they asked me to do the PAC. When I was doing the PAC, patient main complaint was headache. So we're giving analytics for treating the headache, and when patient had a fall and presented with femur fracture, posted for surgery, we need to screen head to toe and take careful history, and because patient is had a fracture of femur and the main complaint is headache, and I suspected something else, maybe SH or something. And I asked for doing CT scan, CT brain, but surgeon refused the time. Unnecessarily doing all the investigations, budget case, all these things. But I told to do mandatorily because patient complaint is headache, main complaint. Then I agreed. Then the patient having SAH. So we postponed the case till SAH is recovered. Then did this. So identification and very early and careful evaluation is mandatory. If we have any doubt of either traumatic head, traumatic SAH or this aneurysmal SAH.
Sir, one thing actually, finally, I forgot to add one point, sir. The
Yeah.
patient with traumatic SH I have a doubt when patient is having SH with traumatic brain injury, can present with vasospasm. I read
Okay.
the literature. If they have a thick SH, usually it is a brain has a very good homeostasis. It will clear the blood as early as possible. Because aneurysm rupture has a continuous leakage, but the traumatic is will be small vessel, maybe small vessels might be causing the problem. They can also have a delayed cerebral ischemia. You can find out with the transcranial Doppler and thing, but oral nimodipine is not recommended as a prophylactic in the traumatic brain injury at this point of time. But if patient presented with delayed cerebral ischemia, you are confirmed with transcranial Doppler or with the CT angiography or delayed cerebral angiography, you can start the oral nimodipine or intravascular nimodipine. You can go with or milrinone. What they found in the literature, sir.
Right. Any questions?
Sir, Surendra, how to tackle cardiac complications in these patients?
Sir, cardiac complication definitely will be there, sir. You need to maintain the rhythm, and if you have patient is having the cardiac dysfunction along with the delayed cerebral ischemia, going with the catheter directed therapy is the best than the augmenting blood pressure, because it increases the more risk on the heart thing. And always decrease the fluid overload on the heart, maintain the rhythm, and keep the heart rate at control, correct the electrolytes, sir. And I think you cannot use the you may not use this. Is usually stress cardiomyopathy because it is a high sympathy surge is causing the cardiac complication in SH patient. You need to definitely calm the patient, make sedate and give analgesics, decrease the fluid overload. You can use the diuretics if patient is fluid overload having pulmonary edema. Sir.
Hello.
Sir.
Tamu.
Sir.
Tamu, nice talk, detailed talk. Just to substantiate the lecture, a few points. And previously it used to be, there used to be a blood pressure target in SH, like more than 160. If your target is less than 160, the chances of rebleeding is less. So, but the recent guidelines, as you have already explained, so the recent guidelines say that there is no specific target of blood pressure.
Yeah.
but the reduction of BP should be done. You have to use an antihypertensive, but you have to decrease your BP gradually. But there is no specific target that maintain a BP of less than 160. So this is one point. Second thing is, yes, there is regarding the use of tranexamic acid. Yes, previously there used to be a recommendation, which after the meta-analysis in 2022 proved that there is no benefit of routine usage of tranexamic acid in SH, but there is a difference in opinion from Neurocritical Care Society and AHA guidelines. So AHA guidelines follows the 2022 meta-analysis, but Neurocritical Care Society recommends against tranexamic acid. So AHA says maybe you can, in some cases, you can use and individualize your therapy, but Neurocritical Care Society completely says you can't use tranexamic acid as a prophylactic to decrease the rebleeding rates. So third point, what I want to say is, I think DCA, desirable ischemia, is a clinical diagnosis rather than a radiological diagnosis. I think you agree with that.
Definitely, but if you have a clinically deterioration, you need to first manage these two things, volume and maintain.
Yes.
Avoid the hypotension.
What I want to insist is, it is a clinical diagnosis rather than a radiological diagnosis. So the definition says a new onset decrease in the GCS less than 2 points. Okay, so it doesn't actually mention any angiographic or TCD velocities. So which makes a thing that the clinical deterioration is itself says that there is a DCA.
And you need to see the confounder also. There is a
Yes,
problem.
yes,
You
definitely.
you need to see for the
yes.
confounders.
Yes, definitely. You have to rule out the
actually think 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 acid. Actually, target velocity, if it is increasing target velocity, Lindgard ratio is increasing, suspect and confirmation you can go first, otherwise maintain the blood pressure and volume and do a CT scan to know about the confounders. If you rule out the confounders, still the sensorium is not improving with your routine management, then you need to go for angio, that is intervention radiology. That's
yes,
what they give.
Yes. రెండోది ఏంటంటే, as you mentioned, the blood pressure augmentation. ఎలాగా అంటే, మీ normally blood pressure augmentation is done like 10 to 15% increase from the baseline. So you see for at least half an hour to 1 hour. If the patient improves with that blood pressure clinically, if you found that the perfusion is increasing, you maintain at this blood pressure for next 6 to 12 hours. So probably that is the way to augment your blood pressure. As you said, like more than 180 or more than 200 is not the actual criteria. It is that you have to increase it gradually, probably by observing the other cardiac complications.
Actually, specific గా 180 అనే ఏం లేదు. వాళ్ళు ఏమి ఇచ్చారంటే, నువ్వు చెప్పి 10 to 15% ఇంప్రూవ్ చేయమన్నారు. క్లినికల్ గా ఇంప్రూవ్ అవ్వకపోతే అండ్ చెక్ ఫర్ ద అదర్ చెక్ చేయమన్నారు. వాళ్ళు అదే చెప్పి లీన్గార్డ్ రేషియో పెరుగుతూ ఉంటే, ఎందుకంటే ఇప్పుడు మన అక్యూట్ ఇస్కెమిక్ స్ట్రోక్ లాగా మనం తగ్గించేసామంటే ఇట్ విల్ హ్యాంపర్ ద
there is no role of reduction అయితే లేదు. డెఫినెట్ గా there is no role of reduction. And other point is hemoglobin మరి ఎక్కడ తెలీదు, బట్ యాజ్ సచ్ AHA లో రికమెండేషన్ అయితే ఇవ్వలేదు అనుకుంటా.
మొన్న దాంట్లోనే ఇచ్చాడు 8 థింక్ లో ఇచ్చాడు. మొన్న ఇచ్చాడు, నీకు పెడతాను దాంట్లోనే ఇచ్చాడు.
AHA 2023 లో కనిపించలేదు. సో అంటే న్యూరోక్రిటికల్ కేర్ సొసైటీ ఏం చెప్తుందంటే, probably there is no insufficient data to recommend a transfusion when the hemoglobin is more than 7 అన్నట్టు వాటి recommendation more than no specific recommendation ఇవ్వలేకపోయాడు because of the data. బట్ AHA లో ఐ హావ్ టు రీచెక్, ఎందుకంటే చూసాను కానీ నాకు ఎక్కడ కనిపించలేదు. ప్రాబబ్లీ ఐ హావ్ టు రీచెక్.
నేను అంటే నీకు ఫోటో పెడతాను. అదే పింక్ లో ఇచ్చాడు, దీంట్లో ఇచ్చాడు, రెండిట్లో ఇచ్చాడు. నేను షాక్ తిన్నాను, ఇది ఏంటి కొత్తగా వచ్చిందని. ఆడే రాశాడు, నేనే షాక్, అందుకని యాడ్ చేశాను.
ఓకే ఓకే రైట్.
అదొకటి, ఇంకోటి మిలిటరీలో అది వాడుతున్నారు ఇప్పుడు అందరూ. క్లోజెట్ అని
క్లోజర్స్ అంటానికి లేదు. ఎస్, క్లోజర్స్ అంటానికి హై డోస్ స్టాటిన్స్ కి there is no role. And another recommendation is that hyponatremia is mostly because of SADH, which is treated only by euvolemia using of mineralocorticoids. And there is a recommendation against the use of mineralocorticoid in this
సెరిబ్రల్ సాల్ట్
hyponatremia.
టెస్టింగ్ ఉంటే ఇవ్వాలి. సెరిబ్రల్
Ah,
సాల్ట్
that-
టెస్టింగ్ ఉంటే ఇవ్వాలి. అది ఒకటే
yes,
పాయింట్ రాదు సార్. ఇఫ్ ద పేషెంట్ ఇస్ సెరిబ్రల్ సాల్ట్ టెస్టింగ్ సిండ్రోమ్, గివ్ మినరలోకార్టికాయిడ్.
Yes.
ఎందుకంటే బ్రెయిన్ నాట్రీ యూరిట్రిక్ పెప్టైడ్ కాజెస్ ద రిలీజ్, అది ఏం చేస్తుందంటే ఎక్కువ సోడియం లాస్ చేస్తుంటది. సో దాన్ని నువ్వు ప్రివెంట్ చేయాలంటే మరి ఎంత వాల్యూమ్ ఇవ్వాలని తిన్నప్పుడు గో ఫర్ ఏ మినరలోకార్టికాయిడ్ అని చెప్పారు.
Yes.
Okay, Surendra.
Nice presentation, Surendra.
థ్యాంక్ యూ.
Just
Mohan,
adding
sir,
to
any
that-
questions?
Hi, adding to that, actually, most of the times we will concentration on aneurysmal subarachnoid hemorrhages. Actually, if suppose angio comes normal, it means non-aneurysmal subarachnoid hemorrhage. We have to look other causes, especially we have to see the vasculitis workup. And one patient, interesting patient, admitted few years back, actually with subarachnoid hemorrhage, fever and thrombocytopenia. When we did infective workup, it came as a malaria positive. So complicated malaria with thrombocytopenia, which is lead to subarachnoid. And also this vasculitis workup is needed for non-aneurysmal hemorrhages. And one more thing regarding the DCI, and Surendra and Srinivas has added. Actually, this recommended treatment in subarachnoid hemorrhage is if you have a nearby high volume centers, better to transfer there. And few high volume centers, they have a 24 hours intervention radiologist. Whenever as GCS drops, most of the times, most of the intervention radiologists will they take to the cath lab and they will do and they will check the vasospasm. As we have so many confounding factors, but definitive treatment is to diagnose vasospasm and treat that particular segment, I think. Nice presentation, Surendra.
Yes, sir. Thank you, sir.
With Mildenon, definitely you said your radiologist is using Mildenon along with noradrenaline
అవును
to
సార్.
maintain the blood pressure.
యాక్చువల్లీ నేను ఇక్కడ రాగానే ఫస్ట్ అంటే నేను ఎప్పుడు చదవలేదు మిలిటరీ అని వాడుతున్నారు అంటే, దళై ఆయన ఉన్నారు కదా సార్, శివశంకర్ దళై ఒకళ్ళు. ఇప్పుడు మీ దగ్గరికి ఒక ఆయన వచ్చారు కదా, ఆయన పేరు సుమేధ. వీళ్ళిద్దరు వాడుతున్నారు కొత్తగా. అంటే నేను అంటే న్యూ టు దిస్ థింగ్. అసలు నేను ఐవి అక్కడ ఇచ్చాం కానీ ఇది ఇంట్రా ఆర్టరీలు ఇచ్చాం కానీ ఇది ఇవ్వలేదు, కొత్తగా ఉందని దాని గురించి చదివాను సార్ అప్పుడు. బట్ దే హావ్ ఫౌండ్ ఇట్ ఈస్ నాట్ గుడ్ వెల్ కండక్టెడ్ స్టడీ. డెఫినెట్లీ మిలిటరీ స్పాజమ్ అనే స్టడీ రిలీజ్ అయింది. సో దానివల్ల ఇంప్రూవింగ్ ఇన్ ద అవుట్కమ్స్, డిలేడ్ సెరిబ్రల్ ఇష్యూమియా లేదు అనేది ఒక పాయింట్ అనమాట. సో దే ఆర్ స్టార్టింగ్ ఎర్లీ ఆఫ్టర్ కాయిలింగ్ తర్వాత. అంటే ఆయన పెట్టట్లేదు.
Each and every case is starting, sir. Each and every case is starting. They are starting.
Not after developing a ischemia. Prophylactically starting after coiling.
After coiling.
Actually, it's సార్ మిలిటరీ స్పాజమ్ స్టడీ ఏం చెప్పిందంటే స్టార్ట్ ఆఫ్టర్ కాయిలింగ్ అండ్ ఇట్ ప్రివెంట్ ద డిలేడ్ సెరిబ్రల్ ఇష్యూమియా, నాట్ స్టార్టింగ్ ఆఫ్టర్ సెరిబ్రల్ ఇష్యూమియా. సెరిబ్రల్ ఇష్యూమియా ప్రివెంట్ చేయడానికి అంతే సార్ అది. హలో సార్.
Okay, Surendra, nice presentation.
Sir.
Very new points you have summarized in your talk. And thank you all. Thank you, audience, for your active participation. Thank you.
Nice presentation, Surendra. Thank you.
థ్యాంక్ యూ మేడం.
Good presentation, Surendra.
మేడం మోహన్ రావు సార్ 2 రోజులు టైం ఇచ్చి చేసిమన్నారు మేడం. ఏదో నాకు తెలిసింది చేసాను.
IPL మ్యాచ్ బాగా ఆడతావు కదా, IPL మ్యాచ్.
సార్
మోహన్ సార్ తో ఎప్పుడు ఐపీఎల్ మ్యాచ్, ఇద్దరు మోహన్ సార్లతోనే అంతే, ఎప్పుడు ఐపీఎల్ మ్యాచ్ జరుగుతుంది.
సడన్ గా 2 రోజులు నేను నైట్
మా షెడ్యూల్ కాదు కదా, వేరే వాళ్ళది కదా.
Surendra, risk of rebleed percent ఎంత అన్యూరిజం క్లిప్పింగ్ లో, అండ్ అప్పుడు ఏం చేస్తారు?
మేడం మేడం క్లిప్పింగ్ అంటే ఇప్పుడు క్లిప్పింగ్ హ్యాస్ లెస్ రిస్క్. డెఫినెట్లీ కాయిలింగ్ బాగా చేస్తే డెఫినెట్ గా తక్కువ. కాయిలింగ్ సరిగ్గా చేయలేదు అనుకోండి మేడం, రీబ్లీడ్ అయ్యే ఛాన్స్ ఉంటుంది. అండ్ యూజువల్ గా ఏంటంటే దే విల్ అంటే వీళ్ళకి ఎక్కువ మల్టిపుల్ ఎన్యూరిజం ఉండే ఛాన్స్ కూడా ఉంటుంది చాలా మందికి. అది కూడా మనం రూల్ అవుట్ చేసుకోవాలి. రూల్ అవుట్ అంటే ఇట్ డిపెండ్స్ అపాన్ సర్జన్ మేడం స్కిల్స్. ఇప్పుడు వైడ్ నెక్ ఉందనుకోండి, డెఫినెట్లీ ఇట్ హ్యాస్ హై రిస్క్. అంటే నేను స్పెసిఫిక్ గా మీరు పర్సంటేజ్ అంటే నేను అంత దాని గురించి అంత స్పెసిఫిక్ గా చదవలేదు మేడం. కానీ వైడ్ నెక్ ఉంది, కాయిలింగ్ మొత్తం ఆర్బిట్రేట్
It ranges from 40 to 70%, starting from day 2 to day 8.
ఏంటి అంత ఎక్కువ ఉంటుందని? ఒక్క నిమిషం
Mhm.
చేసిన చదివినట్టున్నాను, ఒక్క నిమిషం దీన్ని.
And this is a previous data. That's what I'm saying. అంటే 2020-21 వరకు కల్పించిన డేటాలో 40% వరకు to 70% వరకు ఉంది.
50% రీబ్లీడ్ బై 6 months. బట్ సెక్యూర్డ్ లో అంటే యాక్చువల్ వాళ్ళు ఏం చెప్పారంటే మేడం, అన్సెక్యూర్డ్ లో అయితే దేర్ కుడ్ బి రిస్క్ ఆఫ్ అరౌండ్ 5%. అంటే ఆ గైడ్ లైన్స్ లో ఇచ్చారు 5 to 6% ఉంటుంది అన్సెక్యూర్డ్ రికవరీ అయి వెళ్ళిపోయినా. సెక్యూర్డ్ లో అయితే ఫుల్ గా సెక్యూర్ చేస్తే తక్కువే ఉండొచ్చు అని చెప్పారు. బట్ ఇదంతా
యాక్చువల్గా ఈ ఫ్యాక్టర్స్ ఉంటాయి, ప్రీవియస్ హిస్టరీ ఆఫ్ సెంటినల్ హెడేక్, స్మోకింగ్, ఇవన్నీ వీటన్నిటికీ దెర్ విల్ బి అన్ ఇంక్రీజ్డ్ రిస్క్ ఆఫ్ రీబ్లీడ్.
అంటే నేను చదివిన అలాంటి మన అంటే నేను అంత ఇంటెన్సివ్ కేర్ బేసిస్ మీద చదివాను మేడం. ఐ థింక్ రీబ్లీడింగ్ ఇదంతా సర్జికల్ సైన్ కదా, ఆ సైడ్ నేను చదవలేదండి.
బట్ యూ స్టార్ట్ సస్పెక్టింగ్ ఫ్రమ్ day 2, అంటే సెకండ్ 24 hours పోస్ట్ దగ్గర నుండి when the patient has deterioration, అంటే peaks at the 3rd day, rebleed, and vasospasm peaks at the 7th day. ఇది జనరల్ డిక్టమ్ అంటారు.
అది 3rd, 4th డే స్టార్ట్ అయ్యి 21 days,
Vasospasm up to 2 weeks వస్తుంది కదా.
3 weeks
resolves by 3 weeks.
3 weeks.
21 days మేడం.
యా మీరు అన్న నిమోడిపిన్ టు రెడ్యూస్ ద వేసోస్పాజమ్ కదా యూజ్ చేస్తాము.
అవును
అండ్
మేడం.
యూ సెడ్
అవును.
దేర్ ఇస్ నో రికమెండేషన్స్ లో నిమోడిపిన్ లేదు ఇప్పుడు అనేదో చెప్తున్నట్లు.
IV నిమోడిపిన్ మేడం.
ఓకే రైట్.
But IV నిమోడిపిన్ has no role. Only oral has a role.
యు ఆర్ ఇన్ ఐసియు, సర్జరీ అయ్యి వచ్చారు లేదా పోనీ ఇంటర్వెన్షన్ అయ్యి వచ్చారు, యు సస్పెక్ట్ రీబ్లీడ్, రీచెక్ చేసావు, దేర్ ఇస్ ఎ బ్లీడ్ అగైన్. నెక్స్ట్ వాట్ డు వి డు? డు దే గో ఫర్ సర్జరీ అండ్ డు దే నీడ్ జస్ట్ కన్సర్వేటివ్ మేనేజ్మెంట్?
అది యాక్చువల్లీ మేడం మన డెసిషన్ కాదు. విల్ ఆస్క్ ఫర్ సర్జన్. యూ నీడ్ టు టేక్ ఎ షేర్డ్ డెసిషన్ మేకింగ్ కదా. మన డెసిషన్
అది కాదు, మెయిన్ ఏంటంటే హౌ సిగ్నిఫికెంట్ ఇట్ ఈస్ అండ్ హౌ సిగ్నిఫికెంట్ ద clinical deterioration. The patient post procedure, the patient has improved GCS and suddenly deteriorated to certain GCS, అంటే అంత massive bleed ఉన్నప్పుడు you have to definitely reopen. One thing, to evacuate the clot to prevent DCA. Second thing is aneurysm clip. Yes, the same thing. అదే అంటున్నాను, క్లాట్ ఎవాక్యుయేషన్ అనేది కంపల్సరీగా చేయాలి. రెండోది ఏంటంటే క్లిప్పింగ్, ఎక్కడైనా క్లిప్ మిస్ అయిందా అనేది రెండోది చూసుకోవాలి. సో ఈ 2 పాయింట్స్, ఇఫ్ యువర్ బ్లీడ్ ఈస్ సిగ్నిఫికెంట్ యూ హ్యావ్ టు గో ఫర్ రీఓపెన్, అదో డౌట్ లేదు. అంటిల్ ఇఫ్ ఇట్ ఈస్ దాన్ని ఏమంటారు, ఆల్రెడీ అన్ ఎక్స్పెక్టెడ్ అంటే హై రిస్క్ ఫర్ ద రీబ్లీడ్, అంటే లార్జ్ ఎన్యూరిజం ఉంది అండ్ దెర్ ఈస్ ఎ హై రిస్క్ ఈవెన్ ఆఫ్టర్ యువర్ కంప్లీట్ మ్యానిపులేషన్, దెన్ నో బడీ కెన్ డూ ఎనీథింగ్. అంటే మీన్ స్కేల్స్ ప్రకారం ఇఫ్ ఇట్ ఈస్ అ పూర్ థింగ్, దెన్ బెటర్ గో ఫర్ ఎ కన్జర్వేటివ్ ట్రీట్మెంట్.
సో ఇట్స్ చెక్ ద క్లిప్ పొజిషన్ ఆన్ స్కాన్ అండ్ దెన్ డీకంప్రెషన్, అంతే కదా. And maintain euvolemia and maintain the blood pressure and everything. So
అంతే కదా మరి. ఏదైనా సరే ఏ బ్లీడ్ వచ్చినా మన ప్రోటోకాల్ మళ్ళీ యాంజియోగ్రామ్ చేయండి, లీక్ ఉంది, సో ది ఫెయిల్డ్ మిస్, కొత్త బ్లీడ్ ఉందా, క్లిప్ రిలీజ్ అయిందా చూస్తాం. దాన్ని బట్టి మన సర్జికల్ ఇంటర్వెన్షన్, ఇది సర్జికల్ ఇంటర్వెన్షన్ వస్తుందా సర్జికల్ ఇంటర్వెన్షన్కి వెళ్తాం, అంతే కదా. ఒక్కోసారి కొన్నిసార్లు 2 చేయాల్సి వస్తుంది. యూ హ్యావ్ టు డూ ఫర్ కాయిలింగ్ అండ్ క్లిప్పింగ్ ఆల్సో. చేయలేనివి 2 చేస్తా ఉంటారు.
అంటే బై డిక్టమ్ ఏమంటారంటే విచ్ ఎన్యూరిజం కాంట్ బి కాయిల్డ్, కాంట్ బి క్లిప్డ్ ఆల్సో. అంటే అంత లార్జ్ ఉన్నప్పుడు ఇట్ ఈస్ డిఫికల్ట్ టు క్లిప్ ఆల్సో. బట్ ఏంటంటే
ఫ్లో డైవర్టర్స్ వేస్తాం మేడం వాళ్ళు ఏంటంటే వాళ్ళు ఏం చెప్పారంటే మా ఇక్కడ వేస్తా ఉంటారు అనిల్ కుమార్ దేవరా ఆయన శివశంకర్ ఫ్లో డైవర్టర్స్ వేస్తారు. సో దానికి ఫ్లో ఎక్కువ వెళ్ళకుండా పెద్ద ఎన్యూరిజం ఉందంటే డెఫినెట్లీ ఫ్లో డైవర్టర్స్ హ్యాస్ అ రిస్క్ ఆఫ్ ఫ్రీ బ్లీడ్, బట్ డెఫినెట్లీ అట్ ద పాయింట్ ఆఫ్ టైం వాళ్ళకైతే బ్లీడ్ తగ్గిస్తుంది. అక్కడ స్టెంట్ వేస్తారు, సో దట్ అటు ఫ్లో వెళ్ళకుండా చూస్తుంది.
Thank you, Surendra. Nice class. I hope students and juniors are there in the class. మెయిన్ గా ఇవన్నీ వాళ్ళు కొంచెం తెలుసుకోవాలనే కదా ఇన్ని చెప్పేది, ఇన్ని క్వశ్చన్స్. థ్యాంక్ యూ.
Thank you, David. Thank you, Surendra.
Sir.